Hello, everyone, and welcome to today's panel, Long-Term Caregiving Challenges and Opportunities. In this panel, we will dive into the lack of adequate support for caregivers, both professional caregivers as well as unpaid family caregivers, and the challenges and opportunities for improving the working conditions for the direct care workforce and for improving the supports for family caregivers. As we'll discuss, the lack of structural supports for caregivers reinforce societal inequities based on race, gender, geography, and disability, among others. My name is Lindsay Hong. I am the California director with Hand in Hand, the Domestic Employers Network, based in the Bay Area. Hand in Hand organizes domestic employers, so employers of house cleaners, home attendants, and childcare providers. And we work in partnership with domestic workers to support universal family care, and that includes universal long-term services and support. We also work towards dignified working conditions for domestic workers. I'll just say that I have the honor of working with home care workers in California who are organizing for their rights, alongside people with disabilities of all ages who recognize that their rights are also connected to the rights of their employees. I've also witnessed my parents who both cared for their aging mothers until they passed with incredible tenderness, and got to see the dedication of caring home attendants who supported the caregiving of my two grandmothers. One in particular, I remember, took a lot of time with one of my grandmothers painting her nails. She was 104 when she passed, and that meant so much to her, just feeling more beautiful. And then another who would bring my other grandmother chocolate. She'd make sure she had her chocolate every day. And that was something that really brought a lot of joy to her in her final year of life. So for that reason, I'm really glad to be part of this panel and part of this discussion with our two distinguished panelists, Robert Espinoza, Vice President of Policy for PHI, and Latonya Trotter, Assistant Professor of Sociology at Vanderbilt University. I'd now like to invite Robert and Latonya to introduce themselves and share a little bit about how they came into this work. And then we'll jump into the conversation. After they introduce themselves, I have 5 or 6 questions for them, and then we'll open it up to you to ask your questions or share your contributions. So let's start with Robert.
Thank you, Lindsay, and thank you everyone for inviting me to speak today. My name is Robert Espinoza, and I'm the Vice President of Policy at PHI. We are a national research, advocacy, and workforce interventions organization that's focused on strengthening the direct care workforce, and I'm the Vice President of Policy. My initiation into aging long-term care in the workforce happened about 11 years ago. My parents were in their early 70s, and I was realizing the level of support they needed and how under-resourced and fractured the long-term care system was. And I was nervous. I was a family caregiver. I was somebody who wanted to make sure that they would age and live the way they wanted to. And I was surprised to see at the time how that safety net you assume should be there simply wasn't there. The second reason is that shortly after I began working for a national organization called SAGE. SAGE is focused on LGBT older adults, and through that work, I was able to see all the ways in which discrimination, profound systemic inequalities made life difficult, more difficult for LGBT older adults, and the ways in which advocacy in the workforce were critical dimensions to improve their lives. I look forward to the conversation today.
Oh, I guess I'm next, and thank you, everyone. I'm really excited to be a part of this panel and this event. My name is Latonya Trotter. I am a medical sociologist who spends her time studying how healthcare is organized, from formal organizations like hospitals to how it's organized in intimate spaces like bedrooms and apartments and family homes. In terms of how I got into this area of work, I really stumbled upon it. I was doing some work studying a group of nurse practitioners, trying to understand the kind of work that they did with their colleagues and with patients. But it just so happened that the people that these NPs were providing care for were medically frail older adults. And these NPs were doing this work within the context of a community-based organization whose mission was to provide the kind of coordination and direct service provision that would allow older adults to age in place. And so really how I got started is that I really just began to observe that the term age in place covered so much ground, right? That really had been sort of largely unexamined. So there was variation in how localities and states both paid for and organized the things that they paid for. And these kinds of decisions fundamentally shape the ways in which people experienced care, as also in terms of thinking about like how it sort of happens organizationally, that this care is not just happening in single family homes, it's happening in assisted living facilities, supportive retirement communities, as well as being provided by a large network of caregivers, both paid and unpaid. So that was really the experience that introduced me to this work.
Thank you both. So let's hop into our first question. We'll start with you, Robert. What is a benefit and a challenge typically seen in long-term caregiving?
Yeah, it's a great question. I mean, my focus is predominantly on the direct care workforce. And what we see in terms of the benefit is that these workers are enormously valuable to older adults and people with disabilities. Our research shows there are about 4.6 million direct care workers in the country, and it's actually larger than any single other occupation in this country. When we take into account the growing demand for these workers and high turnover rates in this workforce, we estimate that we'll need to fill about 7.4 million jobs in direct care by 2029. This is an incredible challenge, and it directs me to the challenges that we see in this workforce, which is that they're not valued and compensated at the level that they deserve. Typically, workers make poverty level wages. 45% of direct care workers live in or near poverty. They often face kind of inadequate training and career advancement opportunities. They are not recognized or supported in many ways, and the workforce as a whole doesn't receive the same level of public investment as it deserves, right? As older adults and people with disabilities and workers deserve. As a result, turnover in this sector is incredibly high, and increasingly employers are struggling to recruit workers. So it's a challenge that's affecting all of us, and it will only get worse in the years ahead.
Well, you know, it's really interesting for me to sort of think about this question, because in some ways I feel like the challenge is knowledge, or what I will keep referring to during this panel as the refusal to know these kinds of problems and that they exist. Because I don't think most people really understand how much of long-term care relies on uncompensated work. And so both we're talking about the folks that sort of paid workers that Robert was referring to, who are, being, very lowly paid for the work that they are doing, but who also end up doing a lot of other invisible work that's not compensated at all, but also thinking about family and community members who do this work in a formal unpaid capacity. And so, one of the things that we saw, for example, during COVID is what happened when nursing homes that are chronically understaffed closed their doors to the unpaid workforce. And so many of these free laborers were not able to enter into these spaces in order to sort of do this work. And so we began to see how much nursing home care, for example, relies on family members, not just the specific residents. I think we all know intuitively that it matters if your family members are coming to see you, but it's also true that when family members come to help Mr. Johnson, that also allows aides to spend more time with Ms. Jones, who may not have family, right? And so, we saw that organizations, really were relying on this kind of care in ways that really, ended up having disastrous consequences for the folks who are living in these spaces. And we also saw that organizations that long-term care organizations organizations often contract with, often as a sort of voluntary basis or on a very cheap basis to provide things like social activities, could also not come into the facilities. And so I think that that is, really one of the major primary sort of challenges facing the healthcare, the long-term care industry, is that it's not just that it's underfunded. It works through, it is built on the sort of underfunding, and it's sort of built on not having the folks to do this work. And so all kinds of folks who are unrecognized as being a part of keeping this industry afloat are keeping it afloat. And I think it's important to point out that there are some folks as a part of this industry who are making tremendous amounts of money. So we also have this sort of imbalance where it's not just that, this care is poorly compensated or uncompensated. On the other hand, we have people who are literally making money off of the backs of people who are providing this uncompensated care.
Thank you for that. And Latonya, you began to answer this question already, but the next question is how you have seen long-term caregiving change during the pandemic. So can you say more about that? And then Robert, it'll be your turn.
Yeah, I mean, I think one of the things that we saw happen was really the production yet invisibility of isolation, right? So thinking about the ways in which residents of nursing homes, of assisted living facilities, of HUD-funded low-income retirement communities were literally locked in their rooms or their apartments for long stretches of time. And I think that the real impact of that isolation that we saw was really quite catastrophic. And so I think I talked before about the ways in which doors were closed to folks who provide material support in the long-term care space, but also the sort of lack of emotional and social support. And I think, that there are some ways in which we haven't really been able to assess how that might have contributed to many of the deaths that were happening for folks who were living in their homes in assisted living facilities or in nursing homes. And I think there's also ways in which, one of the things that shifted was how the work for healthcare workers themselves shifted. I think one of the things I haven't seen talked about is really the ways in which many of these healthcare workers had to act as virtual jailers, right? It became their job to sort of keep people, right, in their apartments or in their rooms. And I think there hasn't been very much work or focus on the on how the pandemic has really sort of reshaped what the sort of doing of that work looked like. Because again, I think if you think about this work as just being a set of tasks, right? You can think about the ways in which the pandemic might have reordered or added some tasks, but it's also about relationship, right? So what does it mean when you have a sort of force or a happening that fundamentally puts a tremendous amount of stress on the relationship between the person being cared for and the caregiver, right? And so I think, I'm not an infectious disease specialist, so I'm not arguing that there weren't some real and hard choices that needed to be made. But I think one of the things that we saw was how little policymakers, both at the organizational level, at the system level, and at the national level, really didn't consider or weigh these kinds of impacts in the same ways in which the sort of medical parts of care were made visible.
If I can build on Latonya's answer, I mean, I think really the pandemic has helped illustrate for so many people who gets to survive a health crisis and who doesn't. It had a disproportionate impact, as we all know, on older adults, on people with disabilities, on people of color, on essential workers and low-wage workers who were on the front lines from day one. And it really impacted the way in which, I think at least early on, how we talked about who this crisis was affecting. I think as essential workers, I would point to 3 points, 3 potential impacts on the direct care workforce. One is that workers were being forced to put their lives at risk, and there was really no safety net for them. So they were being forced to make the impossible choice between going to work, risking their health and their lives, the health of their clients, the health of their families, and then not having paid sick days, and in many cases, not even health coverage to be able to take time off if someone got sick. And they were being asked to do this for jobs that were paid $12 an hour at most, and that really put them in a financial quandary in terms of whether they were able to survive this crisis. Someone asked the question if there were emergency protocols within long-term care facilities, and the answer is it's maybe, maybe not. The challenge is that the long-term care sector varies in its regard to long-term care procedures across nursing homes, across residential care settings, and across home care. And we don't know the extent to which employers were prepared, especially for an unprecedented health crisis. We do know that the workforce, the direct care workforce, contracted in the first 3 months by about 300,000 workers, although our latest data shows that those numbers are starting to even out. We'll get a sense of what that looks like in the long term. And because there's limited data on direct care workers in nursing homes and across the home and community-based services systems, we actually don't know the extent to which workers contracted COVID-19 and the extent to which they died, which is a major gap in the visibility of this crisis in these workers.
Both. So one of the questions asked about emergency protocols, and this question relates to resources. So what new resources have been created since the pandemic or in response to what has been learned thus far from the pandemic? And Robert, why don't you start with this one?
Thank you. We have seen a number of resources that have been developed since the beginning of the pandemic. At PHI, we're a national research and advocacy organization, and we issued surveys of providers and workers and researchers and policymakers to understand their needs. We issued regular analysis by the week in the first few months on different aspects of how federal and state leaders should respond. And in October of last year, we issued an original report on job quality among direct care workers and the COVID-19 crisis, where we put forward a framework of 5 pillars to improve job quality for these workers. I think this also coincided with a time where there was really a call to action as a country and as a world around the issue of systemic racism and police brutality. And so we also saw increased resources on racial injustice, the impact of nursing homes and COVID-19, and essential workers. And I think we saw a wide range of journal articles and analyses in this regard. Policymakers tended to adopt temporary measures. So we saw numerous states adopt hazard pay measures that have since expired that increased wages for these workers. Also the ability to hire new certified nursing assistants that bypass training requirements. We have a lot of questions about some of these measures. Some of them should be kind of sustained in the long term, like wages. Also allowing workers to bypass training requirements is probably not the safest and best approach for a workforce that is already devalued. And we're continuing to see, I think, new data and new analyses on these workers that I hope move us through the recovery and into a long-term response. So it's very promising, but I think there's still gaps that need to be addressed.
Tanya, before you get started, I just wanted to be sure our interpreter's doing okay. I realize that everyone's talking pretty quickly, and that I think we only have one interpreter. So how are you doing, Elsa? Do we slow down? We're doing okay? Maybe slow down a little bit. Okay, great. Thanks. Go ahead, Latonya.
It's always a good reminder to slow down. I have a penchant for speaking a little quickly. So thinking about answering this question of resources, I think that there are 2 things that have been created during the pandemic, one of which is sort of critical awareness of the depth of the problem and how that has sort of opened the door to some real pathways for political and economic change. So what do I mean by critical awareness? I think the pandemic has really highlighted for many, many, many people the ways in which we have sort of structural things that really just don't work. And it's helped people to see that so many of the kinds of policy questions and initiatives that have never really been on the table are finally on the table, right? So it's no longer just long-term care experts or folks who are sort of trying to make the decision about how to care for someone who know that long-term care is underfunded and understaffed. It's now something that everyone knows. The terms of care work and caregiving have become more mainstream. It really was, prior to this, it was sort of a term that people didn't really know what to do with. They thought it just meant emotion or affection, but now people are really beginning to sort of see, the scope of this work. And I think because of that critical awareness, people are starting to listen to folks who have been working in this space for a very long time, begin listening to those folks and are able to sort of make some real changes. I mean, I've been really impressed by some of the initiatives that the Biden administration has come up with, and in terms of thinking about, certain kinds of, it's not just the actual policies, it's also the language around those policies, right? Again, not being afraid to use words like care, caregivers, and care work. And I also think in terms of, again, thinking about the sort of door being opened, I've been really, really excited to sort of see the kind of headway that political organizations have been able to make in this space. Again, these are folks, they didn't just spring up today. They've been doing this work for a long time, but they're able to sort of make traction in a very different kind of way because the conversation has changed. So for example, I've been really impressed in sort of seeing the kind of publicity that nurses unions have been able to sort of, the impact that they've been able to sort of make in the sort of public sphere, as well as advocacy organizations. I'm a part of a network called the Care Work Network, which is a global sort of group of like-minded scholars, activists, and community members. And we were one of many, many groups who sort of put together a proposal to send to the what was then the new Biden administration for a care agenda. And certainly we've done these kinds of things before, but there was really a sense that we weren't going to be listened to. But I think that there are ways in which we have some evidence that we've been listened to in a very different kind of way.
That gives me hope too. All right, wonderful. So now we're going to get into structural inequities. And Robert, we're going to start with you again. How have structural inequities shaped the jobs and realities of direct care workers?
Yeah, it's a great question, and I think the answer is that it has had a profound impact on direct care workers. When you look at the historical record on home care workers, and specifically wage and overtime exemptions, what you find is that in the early 1930s, when the New Deal was articulating kind of who should be protected by wage and overtime protections, direct care workers were exempt, and it often had to do with the fact that the majority of workers were women, people of color, and increasingly immigrants, I think, in the decades that followed. So it really shows the ways in which, members of Congress were able to employ deeply racist and sexist arguments to exempt workers from protections that have really damaged them for decades. These exemptions were, of course, corrected in 2011 when the Obama administration issued a rule under the Fair Labor and Standards Act. But it obviously had a profound impact for decades. What we also know is that the people that direct care workers support, older adults and people with disabilities, are also disregarded and deal with structural ageism and ableism. And together that compounds the invisibility and the lack of support. By the way, it's an inequity that we see still play out today. Our research shows that women of color within direct care have median family incomes that are $20,000 lower than white men in direct care, and they're lower than white women and men of color. What we know is that median income is typically a measure that takes into account the entire family and a lifetime of experience and discrimination in education and employment, typically since the early years. And so it shows the ways in which that lifetime of discrimination really depletes specifically women of color, of those resources. The other point I'll make quickly is that Medicaid is the primary payer of long-term care in this system. And yet what we know is Medicaid as a program is a politically contested program, and the conservative messaging on Medicaid is often deeply racialized. It falsely presumes that people of color are taking advantage of the system, and it has as a long-term strategy to defund and dismantle Medicaid in the public safety net, right? And so what happens when Medicaid gets defunded or not expanded? It means that workers who rely on this system to strengthen their jobs simply don't get the level of support they should. It's the way in which inequality in a variety of ways impacts these workers.
Yeah, so when thinking about how inequality sort of shapes long-term care delivery, I mean, I think when I first began looking into this area of work, I was really surprised to see that long-term care is one of the most segregated spaces in healthcare, like very, very segregated. Because if you think about it, so much of long-term care provision is linked to where you live, whether that be in terms of choosing a nursing home that's close to sort of family and friends and previous neighborhoods, or even in terms of what kinds of agencies provide home health care services. Has anybody tried to get home health care services? No, it's not really an open market. There are usually certain agencies that service a neighborhood. And so, that the legacy, the US legacy and present of residential segregation then fundamentally shapes how long-term care happens, right? And so I really want to be clear, I'm not just talking about economics as it appears through the lives of racialized people. I'm literally talking about racial discrimination because part of the purpose or the impact of residential segregation is that it allows unequal access to resources, not by the color line, but by seemingly colorblind geographic differences. We see this in schools, we see this in public services, and we also see it in long-term care. And this matters because it means that the kinds of places and agencies that folks have access to in these sort of segregated spaces we have evidence that they're just not as good. And again, this is not an economic story, right? Because as Robert noted, most long-term care services have one payer, right? It's really about who happens to be receiving the care in particular neighborhoods and particular facilities. And this matters not only for the folks who are receiving care, but it also matters for the workers, because a place that isn't a good place to receive care is also not a good place to work. And often workers have similar residential or geographic constraints as those being cared for. They too want to be able to work close to home. They too need to be able to work close to public transit. They too need to be able to work in places where they can access their children's school, in an expeditious amount of time. So, in this context, there are some real key structural inequalities about how people both gain access to care, as well as the folks who were sort of working within this system. And I don't have any data, but I think we're going to begin to find that some of this inequality has shaped some of the high death rates among racialized older adults during the pandemic, because again, nursing homes with racialized populations were probably more negatively impacted by COVID in comparison to nursing homes with majority white resident population.
Thanks, Latonya. There was, I believe, research done in California that demonstrated that exact thing. That nursing homes with more Black and Latinx folks had higher rates of COVID and higher rates of COVID mortality. So let's go to our last question, which is really about what are our dreams for this sector? And so we'll start with you, Latonya. If you could reimagine long-term care to be equitable, what change would you make? And you're welcome to add more than one change. And then what is something you would also keep?
Okay. So in terms of thinking about you know, what I would like to see, I really think we really have to see, right, and acknowledge the value of the work that people do in long-term care. You know, I think, you know, no one questions the fact that supporting the people who do this work, whether through pay, through services, or support, has a cost. But there are so many things that have a cost that we've said as a society that the cost is worth it. So for example, we know that physicians are expensive, from the cheapest primary care doc to the most expensive neurosurgeon. But we never really, it's not a serious proposition that we're just not going to pay them, right? We may tinker with some incentives or payment models, but it would be ridiculous to sort of say that we just don't have enough money. But that's what we do with caregivers all the time, right? And so really, you know, I think part of it is what I would like to see is us getting past this sort of refusal to know all of the work that's actually being required to do the work of caring for folks who receive long-term care services. Because right now it's really that refusal to see that's sort of allowing us to sort of build a system on underpayment and non-payment. And so I think the second question was about, you know, what we would want to keep. I think, you know, one of the things, you know, despite all of its problems, I think long-term care is one of the few areas of healthcare that has really put into action a sort of holistic care-based model. You simply cannot do this work without a team of people pulling together paid folks, unpaid folks, you know, community organizations, people providing all kinds of services. And I really think in that way, you know, it really can be a model for the kind of way of structuring other sectors of the healthcare system. I think that's a real sort of strength. And, you know, I think, you know, the other thing that's also a strength, you know, of this system is, I just lost my train of thought. So maybe I will just stop about what I think the sort of second thing is that we should keep.
Thanks so much, Latonya. If it comes back to you, feel free to chime back in. Robert?
Thank you, Lindsay. I think the one, if I could wave a magic wand and develop something for this system, is I would develop a federal social insurance program in long-term care that would help people afford the cost of long-term care without requiring them to exhaust their income and their assets and impoverish themselves, like what we do within the Medicaid system. Now, there is such a proposal out there that's currently in draft form, and Washington State has developed a state-based social insurance program that does exactly that. But what we know from the data is that long-term care is incredibly expensive. The yearly estimated median costs are somewhere between $54,000 to $106,000 a year, and it can be much higher than that. And yet these kind of costs are difficult to predict for any of us. None of us know how much support we will need as we age, how long we will live, and a severe illness can completely change that equation, and it can completely explode those costs. And so if we create a federal social insurance program in long-term care, we help people offset those costs without impoverishing themselves. I also think the program should be, to reference a report from the National Academy of Social Insurance, a universal family care approach that also includes childcare and paid family and medical leave. And it should also be designed in such a way to improve jobs for workers in the system. All of the items that I've mentioned today and that Latonya has spoken to as well, around wages, around training and advancement opportunities and data collection, because it's important to recognize that we can make the system more affordable, but if we don't strengthen the workforce behind it, we won't make it accessible to everyone. And so I would propose that type of program.
I wish we could put Latonya and Robert in charge of our long-term care system in this country and probably the world. Those all sound like really great proposals, and I also think it's within what's politically possible if we all work together. So I'm very excited about the prospect of where this conversation can go. Now it's a chance to hear from our participants. I know many of you are experts in this field as well, have a lot of lived experience and wisdom. So We'd love for your questions. We also love for your contributions. You can do so by either putting them in the chat, or you can also use the raise hand function. So that's down at the bottom of your screen under reactions. Gives you the option of raising your hand. I did see a question pop up earlier, so maybe we'll start there, and then I think this is a question. So, and then we can gather other questions and contributions. So, let's see. Lauren writes, Lauren Snedker of Rutgers School of Social Work writes, I'm so pleased to be here. As a social worker myself, I'm constantly wondering whether there's literature or research out there about the working relationship between paid direct care workers, in parentheses, HHA, CNAs, and social workers. As a social work educator, I'm constantly teaching my students about the importance of valuing these team members specifically. Latonya, Robert, do you know if there's any literature about those relationships?
I don't know myself about any literature on those relationships, but I think, you know, one of the things, the comment that had flew out of my mind and that has since come back in terms of thinking about what we could keep, sort of in some ways relates to this question, which is that long-term care is one of the few places where we center care as opposed to medical care, or at least we do a better job of doing that. You know, maybe I won't go so far to say we do a good job. That's one of the things that it does better than any place else. And so, for example, I think that, you know, social workers, for example, have a sort of much more visible role often in the space because they're much more likely to have their services paid for, particularly doing the kind of full social service work that social workers are trained to do, as opposed to just sort of, other kinds of sort of task-oriented things that sometimes more medically oriented organizations have. Again, I don't know of any particular research on that question, but I do think that, you know, it is important to sort of note that there are these organizational constraints, that people do the work for which there's a payer. And I think, you know, that's both the sort of possibility of the long-term care space, because more things are paid for in the long-term care sector than in other sectors, but it's still not as much as it should be, right? And I think, for example, it would be lovely if we could continue to sort of center the work of non-medical people who are providing non-medical services in this space, like the work, the sort of supportive care work of home health care aides and caregivers, as well as the sort of coordinating the social service functions of social workers.
If I can build on Latonya's point, I just shared a link to the National Resource Center on the Direct Care Worker, which is a resource center that PHI has run for years. It was funded in 2000, federally funded. And what it does is it compiles a wide range of articles and journal articles and other resources on direct care workers. So there might be an opportunity to search through that to identify resources related to social workers. The 2 points that I would add are that one is that we have seen a growing body of research and literature on care integration and the home care worker, where the argument is that if home care workers are effectively integrated as part of the interdisciplinary care team with doctors, nurses, social workers, and family caregivers, among others, they can actually help spot changes in client condition earlier, and they can avoid kind of the health crises that emerge when you don't do that, and the costly outcomes like emergency department visits and unnecessary hospitalizations. Excuse me, I'm losing my voice for some reason. The other point that I'll make is that I have appreciated in many of these interactions and interventions the social worker orientation and ethos around social justice that is so often essential to understanding why is it that clients and their families are dealing with a wide range of challenges, and bringing that social justice training and ethos into those conversations, I think often helps shed light on the historical dynamics, the systemic dynamics that are changing really people's health and their lives. So I do think there's a strong role for social workers in this system, and especially in these care team approaches.
Great. We have another question that's come through from one of our Caregiver Summit team members. What are some checks and balances, and you started to talk about this actually, what are some checks and balances that can or should be or might be put in place to ensure that caregivers, CNAs, HHAs, et cetera, are properly compensated and supported? You want to take that?
Maybe I'll start and just offer a few. While my voice lasts, I would say that there are two critical measures to start with. One is establishing a wage floor for direct care workers that adequately compensates them for their time, for their skills, for their experience, and ideally increases as they move into advanced roles and as they receive additional training and take on other responsibilities. We might call them minimum wage laws if they apply to the entire workforce, but certainly states have innovated in this way in passing what are just wage floors for direct care workers as one sector. The other piece is the importance of wage pass-through laws, which are laws that require that any increase in Medicaid funding that is meant to go to workers' wages directly go into their checkbooks and into their wages, that it not be in too much or at all by administrative costs, so that we can ensure that that increase in funding, that boost and support, is actually making a difference in their actual compensation. And sometimes those wage floors include wages and benefits, not just wages, but certainly both are essential for these workers.
Yeah, I think, I also have a few thoughts in terms of thinking about the sort of checks and balances. And so I think one of those things might actually just be staffing regulations, right? So we've seen, for example, in the acute care hospital, that hospitals that are in states that have a regulation that says, a nurse can only have so many patients, right? So that means that there can't really be the kind of work speed up that the folks trying to make a profit would like to see, right? So there's a regulation. So you essentially don't allow the folks who are thinking about the money to direct how the care happens. I think that particularly in the in long-term care facilities, those kinds of regulations would simply not allow then these facilities that are making money through mostly tax dollars, right, wouldn't allow them to decide to chronically understaff, right? They would have to figure out another way of making it work if they simply weren't able to do these kinds of things, and so I think that's also really very important. And another, really, this may be pie in the sky, but I think sometimes it's worth sort of dreaming about that pie in the sky, which is that, we really need, a sort of better sort of safety net for all workers, so that you don't have any worker who is essentially trying to make the trade-off between the work that they might find valuable and the work that they enjoy and the work that they are good at, and being able to sort of pay the rent, to sort of take care of their children, to sort of take care of their communities, right? And because I think people are making some of these choices under exigency, right? And I really think that if we were in a system where some of these other things had shifted, right? So we can think about a wage floor for these workers, but we can also think about a wage floor, right? Raising the minimum wage, so that we no longer have home healthcare workers working for $7 and 25 cents an hour in Georgia, right? if everyone's wages go up, right, then you don't have to sort of do this sort of sector by sector organizing. And so I think that is really a larger sort of policy agenda, but one that I think is actually has to be a part of our incremental practical policy approach, has to really be paired with the more pie in the sky things, because we kind of have to know what we're working towards, even as we go for the things that are more practical and more doable.
With you. And just a clarification, that question actually came from Dawn Field. So apologies, Dawn. We have another question here from Nathaniel Bayer, who writes, burnout and wellness within the direct caregiver workforce is an immense challenge. Better payment is part of helping this, but what are other systemic changes or wellness initiatives? So you both just talked about pay, but maybe you could talk about wellness initiatives. And you also talked a lot about the stress of having to make ends meet, Latonya, but are there other wellness initiatives that either of you can touch upon for structural changes?
I can speak to some structural changes and some issues that we have seen in regard to wellness and to mental health in general. One is that I don't think as a sector or as a country, we talk enough about mental health and its specific impact within these kinds of occupations. We don't have a lot of original data or research about why burnout and mental health challenges, how often this happens within the direct care workforce, the various reasons, the impact it has on workers, on the people they support, or on the entire system through economic cost, et cetera. And this was a major issue that had happened in the first few months of the COVID-19 crisis, where workers were seeing a number of their residents and clients pass away, or their own family members, and yet often did not have either grief support or bereavement leave to address these issues, right? And so we have seen anecdotally, because of the lack of research in this area, many workers choose to leave direct care because emotionally it's too much, and they have better paying options in retail or fast food as two examples, which is just a huge problem for this country, right? So I do think it starts with us asking, why haven't we focused on mental health in workers? And maybe one solution could be to make sure that all those federal surveys that are surveying health and wellness and mental health, that they include occupation-specific questions so that we can tease out data on direct care workers in those surveys and really build the knowledge.
So I have a personal penchant that the more that I talk, the more sort of Marxist I get. And so, you know, there is always a part of me when the question comes up about, burnout is, and thinking about sort of stress and wellness, there is a part of me that thinks to myself, they're burnt out because the structure of work burns them out. And there is no pizza party, there is no appreciation day, there is no free yoga in the park on Saturday on your day off that is going to make that really any different. And some of that is the stress of the job, and some of it is the stress of being poor. I think that in some ways, we have to just acknowledge that being poor is a stressor. We have to acknowledge that many, for example, certified nursing assistants who work in nursing homes have multiple gigs, right? They go from place to place to place to place, right? And thinking about how, just that kind of scramble all the time to figure out how to make ends meet in a kind of uncertain but creative way is part of the difficulty. I have spent some time with home healthcare aides, for example, who are working for agencies that give them 30 minutes of paid transportation time from houses, right? And it's like, if you're taking public transportation, that's literally not possible. So essentially what you have is, workers having to cut corners one way or another, both, either for themselves or for the care that they provide. And I think sometimes we think that, people cut corners because they're not invested. It's like, there's often this kind of, stress, this sort of moral tension where folks, really don't want to sort of cut corners on care, but they feel compelled to do that at least sometimes, or not, they sort of hold it on themselves. And so I really think that if people had some space and time, they could figure out some of their own wellness initiatives. They could decide whether yoga is for them, or meditation is for them, or if walking is for them. And so there's a part of me that gets a little bit suspicious about putting these initiatives in the hands of employers or of industry personnel, not because they're bad people, but simply because I think many of us can figure out our own ways of navigating some stress and burnout if we actually had the time and the resources to do that. But I also think that Robert is right in terms of thinking about the kinds of deaths, right, that folks really sort of encounter on a routine basis is also something that isn't structurally visible. You're just supposed to go right to the next person, right, as opposed to sort of really honoring the experience that you sort of went through. And I think that is one of the places in which I think workplaces and industries can sort of do a better job.
Thank you so much. So we're getting actually close to the end of time, our time, because we need a little bit of time at the end to do some administrative components, including a poll. But I did want to read out the last two questions that were sent to us and then give each of you a chance to respond to one of them. So Kezia Lewins writes, Latonya and or Robert, do you have ideas on how to vocalize and make more visible the core work that non-medical workers do in this sector? Is the first question. And then Sheena Nan McKinley writes, since policy change can be a marathon versus a sprint, how do you track progress or measure impact as you galvanize, organize, and mobilize a wide range of advocates and stakeholders? I thought that. So you could also try to respond to both of those questions, but you only have a couple minutes. Does one of you want to start?
I'll go ahead and answer the question about how to make vocalize and make more visible the core work. I think, Robert sort of held up the sort of interdisciplinary team model, the care model, as something that is effective for patients. But I also think one of the things that happens is that the folks who are part of a team begin conceptualizing that care differently. And so I actually think that having the sort of emergence and replication of the team model means that you essentially create advocates among the team, so that physicians began to have a different understanding of what social workers do, that nurses begin to have a different understanding of what CNAs do, because they're all sort of navigating in one space over the care of a person. And so I think obviously there's sort of the political organizing aspect of it and thinking about awareness and having the language, but I also think that partly is once we organize the work differently, it creates new spaces of awareness for the providers who can then begin advocating for change.
And I would respond to the second question around policy change and sort of how do you track progress and measure impact? It's a big question for us because we're often putting together evaluation plans for our advocacy work. And I would make a few quick points. One is that it's true that some policy change can take a lot of time, but there are actually a number of policy reforms that can happen sometimes within 6 months to a year or 2 years. And so being able to track and identify the variety of short-term and long-term policies that need reform, I think is a big piece of that. But some of the indicators we would use to evaluate, one is we evaluate relationships, the number of relationships and the strength or direction of those relationships at the state and federal level. We evaluate public champions. These are typically elected officials or quote unquote celebrities of some sort who use their public kind of strength to really advocate and support. We try to measure any changes in knowledge, skills, or awareness about workers, the key policy issues, the solutions, et cetera. And we acknowledge that policy progress is usually a continuum, whether it starts with defining the problem, it then moves to developing a proposal, to then implementing and then enforcing it and measuring it and refining it, right? And if you think about policy progress along that entire continuum, there are a variety of indicators that can show the ways in which you're moving a policy through that continuum and not just focus on whether or not the policy was won. Thank you.
Thank you both so very much. I know that I have learned a ton, and as somebody who is organizing long-term care stakeholders in California to win universal family care, starting with universal LTSS and that social insurance program that you were talking about, Robert, I'm feeling so much even more encouraged and hopeful because we have the answers right here in this panel. There's so much knowledge right here, and I think what's great is that while there's so many challenges that have been lifted up in this sector, there's also incredible solutions. We know the solution. And yeah, I know that we have to turn it over to Merit to do the wrap up, but Robert and Latonya, did you want to say any final 1 minute, 30-second closing?
I'll just simply say that you know, this is a time with a lot of challenges in terms of thinking about long-term care. You know, we are a society that is sort of in a moment of trying to sort of rethink you know, how we're going to sort of organize and pay for care. But it's also a very exciting time for change. I mean, I think that we are living in a moment in which there's so much potential to get to the sprint part of the marathon in terms of thinking about policy changes.
And I will say ditto to all of that. And a big thank you to both of you and to everyone for featuring this conversation and for inviting me to speak. Thank you.
Thank you all. I would just like to say that I truly appreciate the three of you. I've learned a lot from you along the way, and I look forward to actually the collaboration between the three of you. I feel like you all have a lot in common and to share, and I hope that everyone enjoyed this panel as much as I did. Your Whova platform has prompted you to fill out a poll. Please do that. We would truly appreciate that. And I am just going to share my screen for our closing slide. Oops, that is not the screen I was needing to share. One moment. All right, so, oops, sorry. So we'll now be taking a 10-minute break from 2:40 to 2:50 Eastern, 10:40 to 11:50 Pacific. And please join us for our next session. The policy track is doing Caring for the Caregiver, Tools and Resources. Equity is Championing Dignified Caregiving, Spotlight on National Domestic Workers Alliance. And I am not a Spanish speaker at all, so Visión y Compromiso. And innovation is show and tell resources for caregivers across the spectrum. I'd like to thank everybody, Latonya, Lindsay, and Robert, and I hope you have a great afternoon.